Hello. I think we are
Ma'am,
live.
please start. Yes.
Can we start?
Yes, ma'am.
So, welcome everyone. Good evening. I'm sure that you are preparing well as we are gearing towards our NEET PG exam. Very few days are left. The countdown has already begun. So, I'm sure that you are confident and happy studying in a very positive mood. Yes, friends? Guys, if you have given the test, the level of the questions, how did you find that? I've taken some very important topics, some things which you must know before you give your exam. Everything, every word which I'm going to discuss with you today is going to be very, very, very important. So, did you give the exam? I hope you like the questions. Some questions I've framed just for you guys. So welcome everyone. I won't take much of your time because it's a very crucial period for all of you. So we'll start today with Ophthalmology 2020 series. That's the series that DocTutorials is doing. And that's for NEET PG 2024. So we have our first question here. Somebody is saying the test was tough. It's okay, Dr. Shubham. It's absolutely fine. Let us learn something new today. If you found it tough, let's learn something. Okay. So here we have our first question. There's an old patient who comes to the OPD complaining of diplopia of sudden onset. So by this very first statement, I have come to know that probably we are talking about paralytic squints, isn't it? Diplopia of sudden onset. So all the paralytic squints, third, fourth, sixth nerve palsy can present like this, isn't it? So first of all, we should know diplopia of sudden onset. Now, he also has a history of diabetes, hypertension. Okay. Now, on ocular examination, the vision was almost fine. Maybe a little decrease in vision is due to early cataract, isn't it? He's in old age, he's an elderly patient, so he might have this little decrease in vision because of this early cataract. Now, when I examined the patient, the retina was absolutely fine. Now, when I checked the pupils showed a very different kind of behavior. There was absent direct and indirect light reflex on right-hand side. So, what is the answer here? Anyone? Absolutely correct, Dr. Pratyusha. You're absolutely correct. The correct answer is third nerve paralysis. Now, friends, first we will quickly discuss what is the feature of third nerve palsy. Then we will talk about the pupillary changes here because the pupillary reaction is a very, very important topic. We all must know that. Okay, we will be talking about both the things together. Now, friends, here we have a patient, a characteristic picture question, which was there in your exam earlier. So very quickly, third nerve palsy will have a ptosis. There is a ptosis, as you can see. The eye is very typically down and out, isn't it? The eye is down and the eye is out. Okay. Now, the next very, very important thing is the pupil. If you see, the pupil is also dilated. Now, please remember why the pupil is dilated, because the sphincter pupillae muscle is supplied by third nerve. So third nerve is gone. So sphincter pupillae will not contract. So pupil will not constrict. Instead, it will be dilated. Okay. So we can say in third nerve palsy, the pupil is dilated. Now, my next question to you. Any condition where in third nerve palsy, the pupils are normal. There is a pupillary sparing third nerve palsy. So we all know the medical conditions as in diabetes and hypertension, isn't it? Diabetic people, hypertensive people will show a normally reacting pupil. The reason is important for NEET PG. We all must know the pupillary motor fibers, the fibers in the third nerve which are supplying the pupil. They are in the periphery. So when they are in the periphery, what will happen? They will only be compressed by the surgical causes like aneurysm. So if the third nerve palsy is due to aneurysm or any other surgical cause, then only the pupil will be dilated. Otherwise, in all the other conditions, the pupil will be spared, like diabetes. Yes? Understood, everyone? So you all know this. We all know the medical conditions. The pupil is not involved. So this may be another question for you all. Now, let's go back to the question where we must learn what is the normal pupillary pathway. So guys, visual pathway, everyone knows. We know visual pathway, we know the lesions of the visual pathway. This year, I'm expecting one question from the pupil, okay? We are expecting one question. So let us quickly go through the pupillary pathway. So friends, I am sure that first of all, you know that afferent nerve for the normal pupillary reaction is the optic nerve. What about the efferent nerve? The efferent nerve is the oculomotor nerve. Okay, so afferent is the second nerve. The efferent is the third nerve. Okay, first of all, you must remember that. Now, afferent nerve, the optic nerve, which starts from the retina, goes back. There is a crossover at the chiasma also. But instead of going to the lateral geniculate body, like in visual pathway, the fibers do not go in the lateral geniculate body, lateral geniculate nucleus. Rather, they go to the Edinger-Westphal nucleus. Okay? Understood? Now, how the Edinger-Westphal nucleus? It actually goes through the pretectal nucleus. So, there is something which is called as pretectal nucleus. Then there are internuncial neurons. And finally, they go to the Edinger-Westphal nucleus. Now, from this Edinger-Westphal nucleus, the preganglionic fibers, they come, they take origin, and the third nerve finally goes to the sphincter pupillae muscle, and there is a constriction of the pupil. So you must remember this pathway, guys. This pathway is also very, very, very important. Okay? Dr. Neemra has asked us the order neurons. Haan, bache, please listen to this. The order neurons are for visual pathway, not for the pupillary pathway. So the first order will be rods and cones. Second will be B, bipolar. Third will be ganglion cells. And the fourth one will be the lateral geniculate body. ठीक है बेटा? Understood? Yes? है ना? ठीक है. So friends, again, what do you mean by the direct light reflex? What is this indirect light reflex? So just look at me to understand. When I show torch light in front of my left eye, the left pupil constricts. This is the direct light reflex. The right pupil also constricts. This is because of the indirect light reflex. So guys, try to understand that. Suppose if there is a problem in the afferent nerve, what will be the abnormal pupil? It will be RAPD, isn't it? It will be RAPD. The afferent is affected. What is the afferent? The optic nerve is affected. Okay? But what about the condition where the third nerve is gone, the efferent is gone? So if the efferent is gone, the direct light reflex and the indirect light reflex both will be affected. You have to understand that. Got it, everyone? If only the afferent is gone, you will have RAPD, afferent defect. But if the efferent nerve is gone, the efferent nerve will affect the pupil both in direct and consensual light reflex. Okay? Please remember this one. This is very, very important. So somebody told in the comment section, seventh nerve palsy. But seventh nerve palsy doesn't lead to diplopia of sudden onset. What will seventh nerve palsy lead to? It will lead to lag of thalamus, isn't it? Seventh nerve palsy will actually lead to lag of thalamus. Okay? Please remember, sixth nerve will not affect pupil. Sixth nerve may pupil will be normal. So this is also out. What about second nerve? Obviously, if there is a second nerve problem, first of all, there is a loss of vision. First of all, there will be a loss of vision or a decrease in vision. And what pupillary abnormality you will find? You will actually see a RAPD. Yes, Dr. Pratyusha, you are absolutely right. Okay? Chalo, let's now move to the second question. Another very important topic for your exam. Something from Squint again. So which statement is correct about cover and uncover test? First of all, can anybody answer? Do you think what is the correct statement? So I'm going to tell you this is not very, ma'am, how afferent cause. Ishan, what is RAPD? I'll just tell you very quickly. What is RAPD? So what is RAPD? Hanji, what is RAPD? Okay, RAPD is nothing but like this. Can you check? So if the problem is in the right eye, suppose the problem is in the right-sided optic nerve. The moment you show a torch of light, the afferent nerve, the optic nerve is gone. What will happen? The pupil will not constrict, isn't it? Neither of the pupil will constrict. Now what will you do? You will shift the torch light on the other side. The moment you show the torch light to the other side, the normal side, where the afferent and efferent both are correct, what will happen? The pupil will become small, both the sides. Okay? Now, the moment you bring the torch to the abnormal side again, what will you see? you will again see the pupil becomes dilated. So this is called as RAPD. This is your relative afferent pupillary defect. Okay. Chalo, let's now move to the second one. So unfortunately, the correct answer here is D. This is about your cover and uncover test. So first of all, I'll tell you cover test, uncover test, and alternate cover test. There are 3 tests. Okay, this is a series of 3 tests starting from cover, uncover, alternate cover. Okay? For our FMG students, this is not very important. Alternate cover is not required, but cover and uncover is important. So what is this cover and uncover test? First of all, let me tell you. So in cover test, what do you see? The moment you cover the normal eye. So let us take an example of tropia. What is esotropia? There is an inward convergence of one eye. Can you see? The left eye is going inside. So the moment you cover the apparently normal eye, remember normal eye, what do you expect? What will happen? The squinting eye moves to the center and take up the fixation. This is what we expect in cover test. Okay, this is to confirm the tropias. Okay, please remember. Again, I'm telling you, remember, cover test is to confirm the tropias. Okay, mark my words. It is not for diagnosing anything. It is just to confirm your findings. So here, what we expect. I know there is a squint. There is a tropia. I know. Anybody can say, anybody can see there is a tropia. There is a exotropia. Anybody can say. But when I just want to confirm my finding, what will I do? I'll quickly cover the normal eye. Now what will I see? I'll see the squinted eye will move to the center and take up the fixation. So this is just to confirm the tropias. Have you understood, guys? So cover test is very, very important. It has been there in your exams earlier. Now, because they have asked you cover test, they can of course ask you what is uncover test. Now, this is the second test. Uncover test means what? Isme kya hota hai? So I'll show you this with the help of a video. Okay, let us see a video. Let us see if this works here. Hanji. Now have a look at this beta. In this video, I'm just showing you what is a uncover test. So this patient doesn't have any squint. Can you see any squint? No, there is no squint. The moment I cover any eye, either of the eye, if there is a tendency to squint, there is a phoria, there is a tendency to squint, what will happen? The eye which is under the cover, it will move, drift, it will move. Can you see? The eye under cover is drifted. So there is a tendency to squint. Have you understood? By covering, nothing is visible. The moment you uncover it, you will see the recovery movement. Have you understood this test? So remember, what I want to say is that uncover test is mainly for phorias. Okay. So please remember, direct test is to confirm tropias. Uncover test is to confirm the phoria or to diagnose the phoria. This is very, very, very important topic. Okay, uncover test. Many students get confused between cover and uncover test. Cover test is for tropia. Uncover test is for phorias. Okay, friends, remember. Now, in cover test, the squinted eye is covered with an occluder. No, no, no. Actually, the normal, the straight eye is covered with an occluder. Okay, so this is again an incorrect statement. Now, by ruling out the other options, we can easily find out the answer is D. But what is this alternate cover test? Let me show you what is this alternate cover test. So in alternate cover test, basically, we are covering either eye. First ye, other one ye. First ye, then ye. Okay, so we are covering both the eyes alternatively. Now, guys, this is a very, very important test. Actually, it distinguishes a comitant squint from a paralytic or an incomitant squint. So I hope you all know the difference between the primary and the secondary deviation. What is primary deviation? What is the secondary deviation? Let me just tell you very quickly. So friends, if a patient has a squint, suppose this is a patient having a squint. So this deviation, the deviation of the squinted eye, when the normal eye is fixating, this is called as primary deviation. Okay. Now, similarly in this patient, the moment I cover this eye, there will be some kind of deviation to this eye also. So this deviation will be secondary deviation. So I want to say that primary deviation is the deviation of the squinted eye already. Secondary deviation is the deviation of The normal eye when your squinted eye is covered. So in comitant squints, the squints which are there from birth or very early after the birth, primary deviation is equal to secondary deviation. This is a very important difference between a paralytic squint and a comitant squint. Now, what happens in the paralytic squints? What will happen? Guys, in paralytic squints, the secondary deviation is always more than primary deviation. Why? Let us see from the picture, from an example. So friends, try to see this patient. This is a patient who is having a problem in his left sixth nerve. The left sixth nerve, there is a kind of palsy. So what is happening? We can see the moment we have covered the normal eye. The moment we have covered the normal eye, we can see there is a lot of shifting from the central point. So here I can say the secondary deviation is more than the primary deviation. Can you see the amount of squint here? Here in this picture, hardly any squint is visible, hardly any. So this is your primary deviation. But the moment you have covered the squinted eye, what has happened? See, there's a lot of deviation. So this is the secondary deviation, which is always more than the primary deviation. So this is demonstrated by an alternate cover test. So guys, this can be a very important expected question in your exams because they have asked you once about the cover test. Okay. So a very important topic, guys. Do not get confused between cover and uncover test. And alternate cover test is what I have told you. So marking you again, the very important points, the take home messages again. Cover uncover test is mainly for the 4 years. For 4 years, I have told you the video also. I have shown you the video also. Okay. Again, the last thing which you have to learn and understand is alternate cover test is mainly to distinguish the comitant squints from the paralytic squints. Please remember, in paralytic squints, secondary deviation is more than the primary one. Okay, bache? Chalo. Let's move to another interesting topic, another very, very important question coming from retina. Okay, so we have a young male who's a 30 years old banker by profession. He has come to your OPD with blurring of vision. On examination, there is a halo around macula. His vision is also dropped. Vision is not very good. But the patient doesn't give you any history of any glasses. But now, the moment you gave him +2 glasses, the convex glasses, his vision improved. He also reports that he has similar history and they just responded very well on their own. So now what do you think is the most important cause? Anyone, what is the diagnosis? Anyone? Anyone, what is the diagnosis here? All right. So I have just twisted the question. It is a topic which everybody knows. The correct answer here is CSR, central serous retinopathy. Okay. Please remember, CRAO in young doesn't present like that. Okay. We can have central retinal artery occlusion in young patients also. But there, you will not have a halo around macula. What is this halo around macula, beta? What is this halo kind of thing? This is nothing but the subretinal fluid which has collected in the macula. What is CSR? It is central serous retinopathy where there is a failure of pump between the RPE and choroid. So what will happen? There will be a neurosensory detachment. Okay, neurosensory detachment. And what are the clues which tells you that? So very, very important is the sex, male. He is also a banker. So, you know, he might be having a lot of stress at work, isn't it? Now, another important thing is that he is telling you the repeated histories, isn't it? So repeated histories, CSR can be repetitive if the risk factors are not controlled. And what about this? Improvement of vision by plus glasses. This is when you have fluid collection. The retina moves little forwards. So the light rays are focusing in front. That's why the patient improves the vision by convex glasses. Another very, very important concept. Okay. Now, someone is saying the answer is D. Please remember, arthritic AION again doesn't present like that. The patient will have altitudinal field effects. Okay? Patient will have alternate field effects, altitudinal field effects. Okay? He will not have sudden kind of presentation like that. Okay? Multiple sclerosis again will not lead to Optic neuritis, and optic neuritis doesn't present like that. We won't have a halo around macula. This halo around macula is very typically your CSR. Okay, beta? Now, let us quickly remember every point about CSR. I hope you all remember 3S: smokers, stress, steroids. Okay, these are the 3 important risk factors. Male sex, and it's also one more. Okay, bache? Now, the patient generally comes to us with complaints of central scotoma. Central scotoma is something like that. You have black spot just right in the front of the field. Hai na? Now, in CSR, we mainly get 2 type of patterns. One is the umbrella pattern, another picture question. Another one is a ink blot pattern. What is that ink blot? This ink blot is hyperfluorescence, which increases in successive frames. So this is your ink blot appearance. By the way, which is more common? Which one is more common? The ink blot or the umbrella pattern? This is more common. Okay, bache? Umbrella is more specific, but this is more common. So a PYQ, they have given you a picture question earlier around the neurosensory detachment. The same picture was there. This is the fluid. वो पूछते हैं कि fluid कहाँ collect होता है? Where is the collection of the fluid? So please remember, the fluid gets collected in the subretinal space, isn't it? It is collected in the subretinal space. My next question for my NEET PG students. Yes. What is this small thing here? Anyone? What is this small black area here? Anyone? So this is called as pigment epithelial detachment. Okay, bache? Please remember, this is called as pigment epithelial detachment. Okay. Sometimes PEDs can also be associated with the neurosensory detachment of CSR. Okay. No, Dr. Philadelphia, this is subretinal. This one is subretinal. This is sub-epithelial also. ठीक है ना? Pigment epithelial के अंदर, के नीचे, there is a fluid collection. All right, everyone. So CSR is another very important topic. Guys, by the way, how do you treat it? So as you all know, if we curtail the risk factors, if we just cut out the risk factors, this is spontaneously resolved. We will wait for almost, 3 to 4 months, not more than that. But the new modality of treatment nowadays is anti-VEGF. So if the patient demands early treatment, we can give anti-VEGF injections as well. So please remember the new treatment, anti-VEGF injections are also the new treatment of choice. Okay, bacha? Hanji, Dr. Pratyusha, I have asked you 2 types of fluid collection here. The most common, the most important is this. This is the subretinal space. But I have asked you, what is this small wala? This small wala is a pigment epithelial detachment. It is different from subretinal. Okay? It's different from subretinal. Very good, Dr. Sahir. It is the breakdown of the outer blood retinal barrier. Perfect. Very good. I hope you remember. In CME, it is the inner blood retinal barrier which is broken. In CSR, it is the outer blood retinal barrier which is broken. Okay, beta? Very good. Dr. Nimra, laser photocoagulation, generally we do not do. Generally. Okay, we try to avoid laser photocoagulation. In some patients, we can do PDT. Photodynamic therapy is better than. Message late appear ho rahe hain, acha. Okay, I'm so sorry. There is a delay. I know there is a delay. Hanji. Okay, you guys are very well answering, but I am getting your answers a little late. I'm so sorry for that. Dr. Sahil, you're absolutely right. We can do photodynamic therapy. So you all know the traditional modalities of treatment. I have just told you that nowadays we are also giving anti-VEGFs in CSR. Okay, beta? All right. Chalo, let's move on to something more with neuro-ophthalmology. I'm sure everybody can answer that. A patient has normal right gaze. Normal right gaze, matlab, when I look on the right side, my right gaze is absolutely normal. Now, it says that on attempting the left gaze, the left eye is abducting, but the right eye fails to go to the left. So right eye is stuck here. This is the picture. Left eye is going, but right is not going. So where is the lesion? Where is the problem? I'm sure everybody will be answering me after a few minutes. The answer is right MLF. So it's a right MLF lesion. Okay. What is this MLF? I'll quickly brief you because there might be few students who are not knowing what is this gaze pathway and the gaze policy. So I'll just very quickly tell you. So friends, when we want to look on the left side, suppose this is the right eye, this is the left eye, and we want to look on the left side. Okay. So for the eyes to move on the left side, what is the governing body? The governing body will be right side frontal eye field. ठीक है बच्चे? Right side frontal eye field. Dr. Nimra, ध्यान से सुनो बच्चे, because your answer is wrong here. Okay? Listen to this explanation. Now everyone, when I want to look on the left side, my governing body is right-sided frontal eye field, which is somewhat here, right frontal eye field. ठीक है बेटा? Now, this right frontal eye field, what will it do? It will give innervation to left-sided PPRF. ठीक है बच्चे? Now, there are two jobs of PPRF. PPRF के दो काम है. What are these jobs? The first is to give innervation to the sixth nerve, which in turn gives innervation to the left-sided LR. और LR ने क्या काम करना है? LR will take my left eye here. Okay, the first thing. Now the second thing. What is the second job of PPRF of left side? The second job is that through the MLF of right hand side, it will innervate the third nerve, which is going to innervate the MR. So both the things will happen together. Okay, मेरे को देखो बेटा, left PPRF, left sixth nerve, and right side ka MR. So my both eyes will move to the left side. Okay, friends, this is your normal gaze policy, gaze pathway. Now, friends, suppose if there is a problem of the right frontal eye field as a whole, right frontal eye field मर गया, तो क्या होएगा? The whole left gaze is gone. This is gone. This is gone. Similarly, if the lesion is in the left PPRF also, the same thing will happen. Same thing. But if the lesion is only in the right side MLF, what will happen? The right eye is not going to adapt. When I am attempting a left gaze, my right eye is stuck here. My right eye is not moving. So this is the explanation. This is the answer. ठीक है बेटा? Dr. Nimra, have you understood? Right PPRF lesion will lead to totally blockade of right gaze. It will lead to right gaze palsy. Am I clear now? Yes, Dr. Pratyusha is absolutely right. This is a correct term. MLF lesion, internuclear ophthalmoplegia. इसको हमने क्या नाम दिया है? We can also call it INO, internuclear ophthalmoplegia. ठीक है? We had one question on 1.5 syndrome beta. They have asked you. So you must know the MLF lesions as well. You must know the INO as well. Okay? I think... हाँ जी, बिल्कुल, बिल्कुल. All of you are absolutely correct now. Any doubts here, you can ask me. And now, before we move on to the next question, I'm asking you the next level question. So what do you mean by 8.5 syndrome? I'm sure most of you must be knowing what is this 8.5. Common sense. What is 8? 8 क्या है? 8 मतलब 7 plus 1.5. है ना? So if 1.5 syndrome is associated with paralysis of the 7th nerve also, and now the facial nerve is also gone because these nuclei are very close to each other. So if there is a paralysis of the 7th nerve along with 1.5 syndrome, we'll call it 8.5 syndrome. ठीक है बेटा? Okay, so this may be another question for you all. This explanation, please remember, and I'll request all of you to practice this pathway once before you sleep tonight. ठीक है? सभी लोगों को ऐसे करना है. For just 30 seconds you'll do. When I want to look on the left, my right frontal eye field, which gives innervation to my left PPRF, my left PPRF, my left sixth nerve, my left PPRF, my right MLF, my right third nerve, and my both eyes go to the left. Okay, everyone, you must try doing this on your own brain, on your own hands. You must do it. ठीक है बेटा? चलो. Now let's move to something very easy. क्या है ये? So we have a young man who's coming to the OPD with sudden increase in floaters. Floaters पता है ना? There are some moving objects, moving opacities in front of the eye. So there is sudden increase in floaters. And he has told you that he's been using glasses for a long, long time. He also describes that there's a lot of stress. Okay? And he has a dry eye also. ये तो normal सी बात है. मेरे को भी dry eye है. Anybody can have stress. Anybody can have dry eye. So this is like something very, not very, you know, very convincing. Now, but when I examine, the vision is also good. Vision is 6/9, but the powers are very, very high. Can you see the powers are very high? So first of all, can I label him to have a pathological myopia? Can I call him to have a high myopia, pathological myopia? Can I say that? Yes or no? Now, the moment I examined his retina, I also had a lattice degeneration in the right eye. Now, what can be best done for him? Anyone? What can be best done for him? So this condition ये है क्या बच्चे? Let me just brief you. देखो इसको, these are very important picture questions also for your exam. Let me tell you, retinal detachment पे बहुत time से question नहीं आया. They haven't asked you anything about RRD since a long time. We don't expect a question from CRO. We expect questions from some different topics. Maybe this is the one. Okay, so let us try to understand. Guys, can you see this lattice degeneration? These are crisscross arborizing pattern. ऐसे crisscross दिख रहे हैं. So this is your lattice degeneration. Mark my words. Near the edge of the lattice degeneration, we can have a hidden tear. Tear भी बन सकता है, क्योंकि these are the weak areas which are found in high myopes, in pathological myopias. Yes, everyone. Now, what are the indications of treatment here and what should be the best management? Now, can anybody tell me, is there a point of doing a LASIK? No. LASIK will rather be avoided because he has a pathological myopia. He has a very high power. Okay. If you at all want to do a LASIK, it should be done under very high precautionary measures, isn't it? Dr. Gajendra, isko RRD hua nahi hai. Try to understand that. I have examined the patient. He has a lattice degeneration. He do not have a tear. He does not have a RD yet. Got the point? There's a difference. There's a difference. अभी उसको सिर्फ एक lattice degeneration है और मैं पूछ रही हूँ कि अब क्या करेंगे? टीयर नहीं है अभी, डिटैचमेंट नहीं है अभी. अब क्या करेंगे? So the best answer here is laser photocoagulation. Okay. Now, please remember the difference here, when to intervene, when to treat, and when to not treat. Okay. Let us understand this. So guys, lattice degeneration can be seen in normal individuals also, but they are common in high myopes, pathological myopes. The indication of treatment is increase in floaters. अगर patient ने कहा है कि floaters नहीं है, there is no increase in floaters, I would have better said no intervention required, let it be there. Got it? But if my patient is saying that there is increase in floaters, he has symptoms, we must laser. So how do we do a laser? This is another important question, beta. इसको कहते हैं barrage laser. What do you do? Barrage. Barrage मतलब you just seal the kind of the degeneration and the expecting tear. We may expect a tear developing in that degenerated area, है ना? ये पतला हो गया है, मेरा कपड़ा पतला हो गया. It can absolutely have a tear. फट सकता है ना? So before it get absolutely torn off, I would do a prophylactically stitching, है ना? So we can't do stitching in retina. Retina में सूचर नहीं लगा सकते, तो क्या करेंगे? We can do a laser. So this type of laser is called as barrage laser. Such a beautiful picture here, guys. Can you see? Laser photocoagulation is done in 2 to 3 rows. Okay. After 3 months, what will happen? This whole area will become a scar. ठीक है बच्चे? This whole area will turn out to be a scar. It will become a scar later on. So no tear will develop further. So this is the best management for lattice degeneration here because there is sudden increase in floaters. All right. We can't do LASIK for very high powers. More than 8 diopters we generally discourage. But remember, Dr. Pratyusha, FDA recommends that LASIK can be done for up to -12 diopters of myopia. Okay? But generally in clinical practice, we discourage more than 8 diopters. Okay, beta? Chalo, now some more important picture questions which can be there in your exam. They haven't asked you such beautiful questions, such beautiful pictures, you know. They haven't asked you yet, but I am expecting someday they will probably. So can you see this is a horseshoe shaped here. This is typically a matogenous retinal detachment. Another beautiful picture of a horseshoe shaped ear here. Okay, there's a loss of contrast between the detached retina and the normal retina. There's a difference between the contrast. Okay. Hanji, this is how the floaters look like, and the patient says the sudden increase in floaters. So this is definitely challenging. Another important thing is a curtain over the eye. Last year's question, FMG exam, we had curtain over the eye, the feeling of a curtain. And so this curtain is typically for our RRD patients. Okay, please remember the curtain wala feeling is also important. Now, guys, I'm expecting one question from any surgery also this year. So let us discuss something about the cataract surgery. So anyone, any answers? What is correct about the cataract surgery? What is correct? Hanji, correct kya hai? So are we using methylene blue dye for anterior chamber, anterior capsule staining? So this is a picture where we are doing CCC, continuous curvilinear capsular axis. है ना? So is this methylene blue dye, guys? What is this dye? I am sure you will be answering in a short while that this is not methylene blue. This is actually trypan blue dye. This is a lovely question which, guys, I have framed for you. Let us check if you can answer. One, I told you this is wrong. What about viscoelastic? So I'm sure that you know viscoelastics. They are of different material. Viscoelastics can be pro-visc, viscoat, bi-visc, and so on. So you may have different kinds of viscoelastics. So viscoelastics are another important expected question for your exam. Let me just quickly tell you. The main job of viscoelastic is this. When we push the viscoelastics inside, they maintain the anterior chamber, hai na bache? And they protect the corneal endothelium also. Very important. See, I'm doing phacoemulsification. The ultrasonic power is going to damage my endothelial cells. So they are very precious for me, very precious. So I can't let them get damaged. So, we have to coat the endothelium with the help of this. So this is another very important job. Now it lubricates and everything, it's the supporting task. One statement I have mentioned that they will keep the pupillary dilatation also intact. So in some cases, when my pupil is constricting, I push a lot of viscoelastic so that my pupil remains in the steady position. So viscoelastics are used so that pupil is fixed and dilated all the time. No. It is a statement which is partially correct, I would say. This is not the this is not the primary thing, which is the job of a viscoelastic agent, but definitely it is helping me to keep the pupil little dilated, but it will not let the pupil fixed in one position. No. Okay. Now, what about pseudo exfoliation? So guys, we had a question 2 years back on pseudo exfoliation, the target sign. So if they have asked you one question, you should know everything about pseudo exfoliation. Hai na? Haan, bache. Dr. Vinay, you are absolutely right. Even I see floaters. I'm not a myope. But if at all there is a sudden increase in floaters or there's a development of flashes, this is an indication of treatment. Okay, beta? And the patient already has a lattice degeneration. There is also a high myopia. He is very prone to develop a tear and RRD. That's why we are doing a prophylactic laser barrage. Dr. Vinay, I hope that you get that. You are absolutely right. All right. Now, I'll be mentioning something more about this pseudo exfoliation, a very important topic. So, दोस्तों, ये pseudo exfoliation क्या है? This is a pseudo material. This is an amyloid kind of material which is liberated from the lens capsule only. ये lens की capsule से निकला and it goes to various places. It goes to trabecular meshwork causing glaucoma. It goes to the pupillary margin. It causes a difficulty in pupillary dilatation during the surgery. When I'm operating a patient of pseudo exfoliation, it is very, very, very challenging, very difficult sometimes. Two reasons. One, because pupillary dilatation is not good. Second, very, very important, when the pseudo exfoliation material gets accumulated on the zonules, there is a high chance of subluxation of lens during the surgery. मैं surgery कर रही हूँ और करते करते मैंने देखा, अरे, lens is tilting, lens is going down, lens gets dislocated also. So it's a very, very important question. ठीक है बेटा? So this is very challenging for the surgeons operating on a pseudo exfoliation patient. Now, the same picture was there in your exam. This sign, I hope you know, this is called as target sign. So if they have asked you target sign, they can ask you anything about the pseudo exfoliation glaucoma. I hope you remember this is the most common secondary open angle glaucoma. ठीक है बच्चे? आगे चलेंगे. Now something, what is flax? What is flax? I hope you also know femto laser assisted cataract surgery. है ना? It's the femto laser assisted cataract surgery. It is done with the help of femto lasers. It is a very high precise laser which uses neodymium glass laser having a wavelength of 1053 nanometers. It is used to make the cuts wherever required. है ना? अब फेमटो लेजर पे आपसे सवाल पूछ सकते हैं कि फेमटो लेजर का काम क्या है? Where are we using femto laser? So guys, where we are making cuts, anywhere we are making cuts, like in cataract surgery, we are making cut at the main incision, the main port, है ना? Then we are making cut in the anterior capsule, opening बनाते हैं ना anterior capsule की, and the third cut is dividing the nucleus into pieces. So this is also a cut. ये भी तो एक तरीके का कट है. So all the three steps are actually made by femtolasers. Please remember this is very important. ठीक है? All these three steps are done by femtolaser. So it will give ease to the surgeon. Surgeon बड़ा खुश है, कुछ करना ही नहीं पड़ रहा है ना? It's not like that. Guys, please remember this is the robotic surgery. Definitely it is a robotic surgery. It is assisting us. It's not doing the actual surgery. बाकी का काम मैंने ही करना है. बाकी का काम a surgeon has to do. Have you understood, guys? Understood the steps of femtolasers, guys? You may have a question from femtolasers. बेटा ये दोनों अलग अलग चीज है. बेटा निम्रा, listen to this, Dr. Nimra. What is MICS? ये MICS है क्या? बहुत ही stupid सी चीज है, मैं बता देती हूँ. So the traditional incision, this is just to bluff the patient. There is nothing wonderful here. This is, let us see this. So the standard incision of PECO is 3.2 mm. What do we do in MICS? इस incision को छोटा कर देते हैं. The incision is made less than 2 millimeter. This is MICS. The rest of the procedure remains absolutely same. फंडा क्या है? फंडा है कि if you decrease the size of the incision, what will happen? The astigmatism will be less. That's it. That's it. ठीक है बेटा? I hope you've understood. है ना? User is absolutely right. It is 1.8 mm. बाकी की कहानी same है. But femtolaser, you can also have MICS plus femto. Both are different. है ना? Both are different things here. All right. Chalo. Now let's move on to the next question. The next question is an easy one. First, I am expecting that you will answer. It's an easy question. I can say my FMG students can also very easily answer because, you know, we have this question every year in the exam. So let's quickly discuss. So we have a 7-year-old child coming with itching, discharge during every summer since 2 years. मेरे लिए ये question खत्म हो गया है ना? He's a small boy, itching, summer. So मेरे लिए this is VKC, है ना? His vision is little less, 6/12. He is allergic to some food products also. So this is also supporting my diagnosis. This patient has some kind of allergy. Now also he has been on olopatadine. वो olopatadine already डाल रहा है. देख रहे हो? Olopatadine, I am sure you know this is a drug of choice for VKC, है ना? Drug of choice for VKC. But this time the itching is very severe. Now I have asked you what is unrelated. Batao. So everyone can tell that this is VKC. Yes, this is VKC. Now, what should be the best answer? So friends, first of all, I would say this is a correct statement. He may develop a corneal ulcer. What is the name of that ulcer? We also know it by the name of shield ulcer. है ना बेटा? Unfortunately, my students who has been participating very, very nicely, they told me an incorrect answer because this is the correct answer. Why will he develop here a bacterial conjunctivitis? I am not in favor of that. है ना? But definitely it is a correct statement. Bache, please remember, these children, VKC children, they have VKC in the early childhood. Later on, they are ones who may develop keratoconus. Why? क्यों हो सकता है इन्हें keratoconus? Because of the repeated itching. When they keep on doing this kind of itching thing, they may change the curvature of the cornea later on. Okay? So please remember, this is a very, very important topic. VKC patients may develop keratoconus later. It's a very important statement. Now, what about this severe itching? He can be given steroids. Yes. Please remember, steroids, low-dose steroids like loteprednol can be given in the initial phase of itching because they are very, very good anti-inflammatory agents. So definitely the itching will become less. Okay? Please remember, this is how we have to. Yes, Dr. Nimra, now you are absolutely right. Because of the repeated rubbing. Okay? So very quickly, we will revise. What is VKC? Who am I? Summers, itching, small boys. My question ends because we are talking about VKC. We have beautiful cobblestone papillae. We may also have what? Horner Tranta spots. What are Horner Tranta spots? These are accumulation of eosinophils on the superior part of the cornea, the limbus. So we may also have ropey discharge, like many students are telling me. There may be Denny Morgan lines. Can you see these Denny Morgan? This is also because of repeated rubbing. Atopic dermatitis में भी होते हैं और इसमें भी होते हैं. ठीक है, डोंट गेट कंफ्यूज, इसमें भी होते हैं. Maxwell line sign is when you have exudation, the ropey discharge which gets accumulated on the palpebral conjunctiva. So that is your Maxwell line sign. Okay, very, very important question. Now, what is this? ये क्या है? This is your pseudogerontoxon. This is nothing but exudation on the limbus. Yes, very good. It is a type 1 hypersensitivity reaction. ठीक है? IgE mediated, and a beautiful picture on the Shields ulcer. So Shields ulcer is another question which may be there in your exam. Okay? अच्छा, ये बता दो, ये Shield ulcer ऊपर क्यों होता है? Whenever you will see Shield ulcer, it is always there in the superior part on the of the cornea. Why? Bolo. Why do we always get Shield ulcer in the superior part on the cornea? Why can't we have Shield ulcer in the lower part of the cornea? Anyone? Okay, the reason now I'm telling you, this type of ulceration is because of irritation by the large cobblestone papillae. तो ध्यान देखेंगे बच्चे. I hope you all know that upper lid covers some part of the superior cornea. So this part is only covered by the cobblestone papillae, gets irritated by those papillae. So we always have ulcer in the upper part of the cornea. ठीक है बेटा? Very good, Dr. Gajendra, because of the upper eyelid. Very good. Very good. Good. Now, let's move on to an interesting topic, something about thyroid eye disease. Batao bache, which is not associated with thyroid eye disease. Is it more common in smokers? Yes, I'm sure you know it is more common in smokers. What is Jelinek sign? Jelinek sign bhi hota hai. Okay, I'm ruthless here. I'm giving you some sign which you might skip during your preparation because everybody knows about the, the Dalrymple sign, the retraction of the lids. Everyone know about the Dalrymple sign. Everyone also know about the von Graffi sign, which is the lid lag. Everyone know about these two signs. But what about this Jelinek sign? क्या है ये Jelinek sign? Guys, can you see this periorbital pigmentation? This pigmentation, है ना? ये जो pigmentation है, ink, है ना? Ink जैसा. This is due to the hormones, है ना? Thyroid will act on the pituitary, then you have adrenocortical hormone, and then this color change. So periorbital color changes as Jelinek sign. So this is also common in thyroid patients. Okay, so definitely this is seen. Elevation is definitely first affected in thyroid eye disease because inferior rectus muscle is first affected. So when inferior rectus muscle is first affected, that is first restricted. It does not let elevation to happen. So this is also a correct statement. But what is incorrect is infralateral dystopia. Please remember, thyroid eye disease will always call a proptosis, not a dystopia. So कौन बताएगा what is the difference between proptosis and dystopia? Proptosis is forward protrusion, dystopia is displacement. Suppose कीजिए ट्यूमर यहाँ पे है, तो आंख कहाँ जाएगा? आंख ऊपर चला जाएगा ना. This is dystopia. Yes. Suppose कीजिए ट्यूमर यहाँ है, ट्यूमर is here. Where will be the eye? I'll displace. I will be displaced laterally and down, isn't it? Malar rash. Malar rash. I haven't heard about this rash, but I can say it's a pigmentation. ठीक है? मैंने तो ये नहीं पढ़ा है malar rash के बारे में, but I'll read if there is something related to thyroid. Okay? हाँ जी. So this dystopia word, please remember, there's a difference between proptosis and dystopia. Last year we had one question from the Hertel's ophthalmometer. है ना? Something from proptosis. They can ask you more about proptosis. Okay? So, by the way, what is that radiological sign that we see in thyroid patients in the orbit? Who will tell me what is that named sign? Hanji, all of you are aware this is your favorite Coke bottle appearance, है ना? इसमें क्या होता है? The belly of the muscle gets swollen, but the tendon remains normal. Tendon normal रहता है, but belly फूल जाता है, belly swollen हो जाता है, belly inflame हो जाता है. ठीक है बच्चे? हाँ, Dr. Vinay, that's what I said. Jelinek sign, we generally do not read this sign, but I am telling you, it is very commonly seen in the practice. Practice में मेरे को बहुत commonly दिखता है. That's why I have mentioned it here. ठीक है बच्चे? Gajendra बच्चे, this this proptosis can be both unilateral and bilateral. Yes. All the signs are mostly bilateral, but they may be asymmetrical. Okay. Please remember, thyroid is the most common cause of unilateral and bilateral proptosis in adults. Most of the time we have bilateral proptosis, which may be asymmetric. Bas. Okay. Good. Now, mind you, that's for Dr. Vinay. Dekho beta. So I just want to show you. I don't want you to bombard with something new just before your NEET PG. I'm just giving you an overview. इतने सारे signs हैं thyroid में, है ना? There are so many signs in thyroid. We are just limited ourselves to these two. At least ये तो पता ही होना चाहिए, है ना? लेकिन जब हम पढ़ाते हैं तो ये at least I tell these signs at least, है ना? मेरे हिसाब से इतने तो पता होने ही चाहिए बच्चे. Okay, so just an overview. There are so many signs related to eye and thyroid. Okay, forget rest of them. Don't get confused at this point of time. ठीक है? चलो भाई ये बता दो, बहुत ही easy सवाल है. ये क्या है? Anyone, what is the diagnosis? Forget about the causes. What is it? बहुत ही simple सा सवाल है. Can my students see these are the flame-shaped hemorrhages? Can you all see there are multiple flame-shaped hemorrhages? Yes, but they are special because inside the flame-shaped hemorrhages, there is a clear center. So very good, Dr. User. This is the picture of rod spot. So what is the most common condition where we have rod spot is infective endocarditis. ये जो medicine में हम पढ़ते हैं ना, infective endocarditis, the rod spots are these. They look like they look like flame-shaped hemorrhages. So guys, you don't have to confuse here. Okay. Now, just to make you aware, please remember something which may confuse you is diabetic retinopathy, hypertensive retinopathy. They can also show you the rod spots. Please remember, leukemias are very, very, very important cause of rod spots for us. है ना? किसी पेशेंट को ल्यूकीमिया है, मुझे रॉड स्पॉट दिख रहे, my diagnosis becomes more easy and powerful. Yes, leukemia is one condition बेटा. जो ल्यूकीमिया में ट्यूमर सेल्स हैं, they will lead to the clear central area in the rod spot. ठीक है? ये बहुत ही important expected question है. All right? Okay, Dr. Prajwal, listen to this बेटा. So carefully सुनो. In adults, the most common cause of unilateral and bilateral proptosis is thyroid. Adults में, है ना? Middle age में भी, adults में भी, it is thyroid. Okay? Children में, it is orbital cellulitis. Unilateral, bilateral, generally it is because of tumors like secondaries in the orbit. Okay? Unilateral, it is generally orbital cellulitis. I hope that's clear, Dr. Prajwal. ठीक है बेटा? अच्छा. Oh, I'm so sorry, बच्चे. Dr. Gajendra, I'm so sorry. If you are saying that it looks like malar rash, yes, definitely it looks like malar rash. Yes, definitely. But ऐसे lupus के फिर अलग symptoms होंगे ना? It will have other presentations. Thyroid, we have different presentations, isn't it? The presentation is different. Okay? देखो उसको क्वेश्चन को देखो ना. Question देखो. Question is this: what is not associated with thyroid eye disease? So according to that, dystopia is never to be there. Okay. Chalo, the next one. So this is a very beautiful, very interesting question, something new, which may be there in your exams, because since last 2 years, they're asking you some questions about syndromes and, cherry red spot. So I have framed one question, try to answer. It's a beautiful question. So we have a 12-year-old boy who comes with a severe visual impairment. है ना? He also reports that the child has night blindness earlier. पहले उसको रात में कम दिखता था, पहले उसको night blindness था. Now there is a decrease in vision. Now the child is mentally challenged also, and there is a hypogonadism also. Can you see? The vision is also less. And in the retina, we see pigmentary changes. So very good, Dr. User. Very, very good. The correct answer here is Lawrence-Moon-Beadle syndrome. ठीक है? सुनो, मैंने options बहुत easy रखे हैं. I have kept the options very easy because I want to discuss this question with you. But you must remember, all of you must remember everything about RP. Probably you'll get one question on RP this year. Okay, everything about RP you should know. You should know everything about Lawrence-Moon-Beadle syndrome and how to differentiate the Bardet-Beadle syndrome or Lawrence-Moon syndrome. ये सब आना चाहिए. So let us very quickly read about RP. So I'm sure you know that RP is idiopathic degeneration of rods and cones. Rods goes earlier. That's why night blindness is the earlier symptom. When cones are also degenerated, the vision decreases. है ना? Now, the classical triad, when I see any patient of RP classically, I see BAP. What is BAP? Bony spicules, attenuated vessels, and a pale disc. This is my classical picture. Okay, beta. Now, I have a question where my RP wala bacha is having some kind of association. I am sure you all know that Usher syndrome, where the patient has a sensory neural deafness. This is the most common association. ये सबको पता है ना? So you may get a question on Usher syndrome as well. Now, Refson's disease में क्या क्या होता है? फटाफट बता दो. Refson's is the second common association. So what do you have? You will have polyneuropathy, है ना? Polyneuropathy हो सकता है, ataxia हो सकता है, cerebellar ataxia हो सकता है. Yes or no? So you may have symptoms or presentation like that. Now, what about Lawrence-Moon-Beadle syndrome? So, बच्चे, very quickly, these child are obese childs. They have mental retardation, hypogonadism, autosomal recessive inheritance. Now, something more. How to distinguish Bardet-Beadle syndrome with Lawrence-Moon syndrome? I'm sure Sandeep sir ने आपको पढ़ाया ही है ये सब. You know everything in pediatrics. But very, very quickly, polydactyly is a feature in Bardet-Beadle syndrome, which is not there in Lawrence-Moon syndrome. And obesity. Obesity is absent here, but it is generally present here. Okay, both the type of children may have a mental retardation. So, you know, this is something which can be there in your exams. Okay? All right, bache. Now, I have a slide here of another important syndrome in ophthalmology. We will be talking about 𝗵𝗗𝗃𝗀 syndrome. So, this is a very famous personality. He's a motivational speaker, beta. So he had 𝗵𝗃𝗃𝗀 syndrome. So it's a typical facial appearance. There's a hypertelorism, mandibular hypodevelopment. There's a droopy eyelid like that. Okay, so these are the features of 𝗵𝗃𝗃𝗀 syndrome. So very, very, very important. ठीक है? चल, ये देखते हैं. हाँ, अच्छा, Dr. Vinay. Okay, listen to this, beta. देखो इधर. In this slide, they have mentioned both the children, Bardet-Beadle and Lawrence-Moon syndrome. According to them, both of them are same. But actually speaking, factually speaking, there's a little difference between these two. Okay, beta? There's a little difference between these two. Obesity is usually not a feature of Lawrence-Moon syndrome, usually. All right? How to distinguish, I'm saying. Both of them, they are in the same spectrum, usually in the same spectrum. But generally, we don't have obesity in Lawrence-Moon syndrome. Okay? Now, is it clear, Dr. Vinay? Now, something very, very easy. Can we answer, all of you? Try. We have a young man who has redness, pain, photophobia. The pupil is small. I have my diagnosis here. My diagnosis comes. What is this? Pupil is small, redness, pain, photophobia. कौन सी condition है? Eye is red also. What is it? This is nothing but uveitis. Nothing but uveitis, isn't it? Now, what is the history? So there is a history of a non-productive cuff. There are tender nodules on the shin. The X-ray also shows bilateral hilar lymphadenopathy. So, what is the diagnosis? Can I say this is a uveitis related to sarcoidosis? Isn't it? Isn't it? है ना? So please remember, sarcoidosis is the very close differential diagnosis for tuberculosis. We have hilar lymphadenopathy, non-caseating granulomas, and so many ocular findings. So many. You name it, and you get it in sarcoidosis. You name it, and you get it in tuberculosis. Okay, both of them. आप जो भी नाम लोगे, वो TB में, sarcoidosis में मिल जाएगा. कोई भी नाम ले दो. Nerve palsy ले लो, pupil affection ले लो, eyelid का problem ले लो, एपिस्क्लेराइटिस ले लो, कंजंक्टिवाइटिस ले लो, यूवीआइटिस ले लो, ग्लाकोमा ले लो. You name it and you have it in sarcoidosis and tuberculosis. Please remember, very, very, very important. Okay? Now, uveitis, something about sarcoid related uveitis, a potential question. So, uveitis is the most common finding, most common ocular feature in sarcoidosis. Mostly it is anterior uveitis. It is a granulomatous uveitis, responds very well to topical steroids. Sometimes you may have to give periocular injections of steroids. Okay, beta? You may have KPs, you may have snowballs, and Dr. Ishan ने बहुत अच्छा बताया. There is a beautiful candle wax dripping appearance. What is this candle wax? This is nothing but periphlebitis. जो vessels होते हैं, veins होते हैं, उन पे perivasculitis, not periphlebitis. I'm so sorry. It is perivasculitis. ठीक है? It's not periphlebitis. I'm so sorry. Dr. Ishan, you are absolutely right. बहुत अच्छा. This is a candle wax dripping sign. All right. चलो, the next question. Another important topic. FMG एग्जाम में बहुत बार पूछ चुके हैं, आपको भी बहुत बार पूछा है, ये क्या है? सो वी हैव अ यंग बॉय, छोटा सा बच्चा है 8 years का. ही इज लिविंग इन अ रिमोट विलेज. ही इज प्रेजेंटिंग विद हिज मदर इन ओपीडी विद डिफिकल्टी इन विजन ड्यूरिंग इवनिंग आवर्स, है ना? And the mother says he has a history of frequent falls during his play hours in evening. उसको शाम को देखने में तकलीफ हो रहा है ना? He is probably having a night blindness. Now, when you examine, his vision was absolutely fine. Anterior segment shows this picture. So पहले मुझे ये बता दो ये क्या है? What is this picture? Dr. User, you are absolutely right again. Very, very good. This is the correct answer. ये पिक्चर क्या है? कौन बताएगा? What is this picture? ये क्या स्टेज है? क्या है ये? कौन बताएगा? My dear friends, you are absolutely right. This is not Bitot spot. This is a stage which is earlier to Bitot spot. This is a dryness of conjunctiva. We call it conjunctival xerosis. Okay, beta? Now, please remember, xerophthalmia is a spectrum of ocular manifestations which may occur due to vitamin A deficiency. Okay? It is not synonymous with dry eye. Dry eye can be a finding in xerophthalmia. Okay, bache? Please remember, the most specific finding is Bitot spot, but this is the earliest symptom. This is the earliest sign. Okay, there are 3 questions here. Night blindness is the earliest symptom. Conjunctival xerosis is the earliest sign. Bitot spot is the most specific sign. Okay, beta? Understood this much? Now, something more. So please see corneal xerosis. This can be picked by various dyes. We had one question from dye, so I want all of you should prepare about the dyes also. So rose Bengal dye, fluorescein dye, lissamine green dye, all 3 of them can be used to pick out this stage if we can't see through the slit lamp. Now, what is keratomalacia? Please remember, guys, though it is a corneal ulcer, but it is a sterile type of corneal ulcer. It's a very, very important question. It's a sterile corneal ulcer. This stage is not reversible. Till corneal xerosis, it is reversible, but now this is not reversible. Now, let's go back to the question. So, Bitot spot is the most specific sign. Yes, we have just discussed. We must check his immunization history because he is in a remote village, and I am sure all of you know that vitamin A is actually given during the immunization process with measles vaccine. So you all must know. Okay. The earliest sign is, of course, conjunctival xerosis. We also have discussed, which is early loss of sensitivity. Loss of sensitivity, I can't read that question. Loss of sensitivity to green light. Loss of if you ask me, the MCQ related, if they don't actually give you the question that loss of sensitivity to green light. But in PG books, yes, this has been mentioned that this is a very early feature, है ना? But if you talk about the MCQs, they have never mentioned this loss of green color in the early phase. Okay, they just mention about night blindness. So we all know about night blindness only, but this is also a very early finding. Definitely it is. All right, Dr. Vinay, this is also a very early finding. Chalo bache. So as everybody has mentioned, the treatment here, the treatment will be vitamin A, but it has to be given 2 lakh international unit because our child is 8 years of age, more than 1 year of age. We must give 0, 1 and 14. This is a dosage schedule. And if we are planning to give him IM dose, the IM dose will be half of it. 1 lakh international unit will be the IM dose. Okay. Chalo. Hanji, something very common which I see in my OPD, very, very common condition and something which everyone should know. Hanji, batao, kya hai? So a patient has come to hospital with a fingernail trauma. On fluorescein staining, there is epithelial defect with intense photophobia. What should not be done? Hanji, what should not be done? Anyone? So the correct answer here is saline wash. Beta, ye hai kya? Dekhiye bache, I'm sure you remember these are the layers of the cornea. The epithelium is a privileged layer because it has stem cells. Suppose there is a little trauma, fingernail injury by a child. What can happen? There may be a defect in the cornea. Suppose if the defect has occurred here, the patient will be very troublesome. He'll have a lot of pain. There is a photophobia. There's a red eye also. Dekho idhar, a beautiful picture here. Can you all see a defect in the epithelium? Beautiful picture. Now guys, remember the usage of fluorescein dye. Isn't it? If we are in doubt, if we can't see that with slit lamp, we can just put a drop of fluorescein and we can check. The areas which are denuded of epithelium will be stained green in color. So definitely if something like this happens, I do what? First of all, in my OPD, I'll put a drop of cycloplegic so that my patient becomes a little comfortable. He has a lot of pain and photophobia. The next is I patch the eye. I just close the eye so that the cornea heals and I bandage it with the antibiotic drops or an ointment. Okay, so this is what I typically do. But some people who do not want to put a bandage here, what can be the second option? They can put a lens, bandage contact lens. These are the different kind of contact lens which are very large kind of lens. So they will prevent the repeated trauma by the movement of the eyelid. Meri taraf dekhiye. So if we have an injury and we just keep on closing the eye by blinking and just doing that, the defect will never heal. The idea is to bandage it. Okay, bache, kab tak bandage karte hain? We do a bandage for almost 24 to 48 hours. This is done and this is done. But wash kyun karenge? Ye to foreign bodies mein karte hain. Hai na bache? Why will we wash? Wash will be done in foreign bodies. All right. I hope this much is clear. Something more on the contact lenses. Can anyone answer? Because I have kept this question as I want to discuss keratoconus with you. So I'm sure you all know that keratoconus can be diagnosed best with topography. Topography kya hota hai? This is pentacam and topography. ठीक है बच्चे? हाँ जी. So he is not having a good vision through glasses. Glass दे दिया है पर उसको cylindrical power इतना ज़्यादा है that he is not comfortable with that kind of glasses. Now, what will I do? If the patient has a keratoconus, there is a cone, but definitely he has an early conus. अब उसको cylindrical number बहुत ज़्यादा है. अब क्या करेंगे? Very, very good, doctor uses. We can give RGP lenses. These are rigid gas permeable lenses, and the prototype is made by Rose. Rose एक बंदी का नाम है. Rose is the name of a female who have made these kind of RGP glasses, and these lenses are different lenses. So just hard nahi dete. Dr. Vinay, the better term is RGP lenses. देखो क्या है फर्क क्या है मैं आपको बहुत briefly बता देती हूँ. We expect questions from contact lenses also. These days आजकल वो बहुत कुछ पूछने लगे हैं. Yes, pentacam is better than obscan here. Yes. ठीक है? Keratoconus, very briefly, it is a conical thing. It is idiopathic condition. It comes in the age of around 15 to 18 years. 30 साल के बाद होता ही नहीं है. ठीक है? It just stabilizes. It doesn't occur. मेरे को नहीं हो सकता keratoconus. Okay, I'm gone beyond that. So, beautiful sign, a Munson sign, notching of the lower lid. This is a picture of pentacam. This is a normal pentacam where everything is good, green in color. Okay, the red ones, the danger ones, the thinning in the center, more curve in the center. This is a danger one, the pentacam picture of keratoconus. What is this is the treatment of choice. We know it by the name of C3R. Corneal collagen cross linkage with riboflavin drops under ultraviolet A light. ठीक है ना? Under ultraviolet A light. Now, अब रोल आता है कॉन्टैक्ट लेंसेज का। तो दोस्तों इसके बाद व्हाट इज दिस, आई मीन व्हाट इज द यूज ऑफ C3R? C3R से हुआ क्या है? C3R से स्टेबल हो गया है। मतलब स्टेबल मतलब इट इज नॉट गोइंग टू प्रोग्रेस फर्दर, isn't it? My cornea has become thicker, my cornea has become stronger, so this will just stabilize. Now cornea to conical hi hai, how will you make the conical cornea back to normal? So this can be done by either of the two things. First, we can put intacts. Last year question aaya tha na, intracorneal ring segments. So either we can do a little surgery, chota sa surgical procedure hai, we put 2 PMMA rings inside the corneal stroma. ये one time procedure है, it will stabilize the irregularities of the cornea. Either we can do that or we can put custom designed RGP lenses. ठीक है ना? ये RGP lenses क्या होते हैं बच्चे? RGP lenses मैंने ये सारा आपको दिया है यहाँ पे. If you get time, you can just go through it again. So जो नॉर्मल लेंसेज होते हैं वो कैसे होते हैं? नॉर्मल लेंस तो ऐसे होते हैं, है ना? फिर अब जो ये कोन आएगा तो कोन को तंग करेंगे. दे आर नॉट गोइंग टू हेल्प टू द कोन एनीवेयर. सो दीज RGP lenses, they have a different kind of shape. They have something like this. देख रहे हो? Something like this. Okay, so they will just, have a very good fit on that conical cornea. And gradually they will make the curvature back to normal, but they have to be placed for a long period of time. That is why they are made with certain material which are very breathable material. The polymers which are used in RGP lenses, they have some very good oxygen permeability. Got it, everyone? Now, what about this soft contact lens or hard contact lens? थोड़ा सा समझ लीजिए बच्चे. Not much details are required. So, soft contact lens first is made up of HEMA, hydrogels and HEMA. हेमा मालिनी बड़ी सॉफ्ट है ना, सुंदर सी सॉफ्ट है, तो हेमा, हाइड्रोक्सी इथाइल मेथेक्राइलेट. ओके, दीज आर सॉफ्ट कॉन्टैक्ट लेंसेज. ना ये हार्ड कैसे हैं? हार्ड इज मेड अप ऑफ PMMA, पॉलीमीथाइल मेथेक्राइलेट. ओके, तो अब ये सॉफ्ट कॉन्टैक्ट लेंसेज का क्या फायदा है ना? फायदा क्या है? दैट दे आर वेरी गुड इफ यू टॉक अबाउट कंफर्ट, है ना? कंफर्ट इज विथ सॉफ्ट. बट हार्ड का क्या फायदा है? Hard will give you more sharper vision, less deposits, and they are more durable. Okay, so remember at least this much. I am just requesting you to just go through this once again. Rose K lens is a type of RGP lens which is used for keratoconus people. Hard contact lens made up of PMMA. Vision is better, more durable, less wear and tear. Soft contact lens, more comfort, made up of HEMA. ठीक है? I think this is clear now. हाँ जी. My next question. So we have a young female complains with decrease in vision. On examination, the vision was less. Vision is pretty less. It is an easy one. There was a difficulty in reading of 𝗵𝗗 chart, but on examination, the fundus is normal. अब क्या है ये? ये तो बहुत सिंपल सा सवाल है, सभी लोग बताएंगे. वेरी टिपिकल प्रेजेंटेशन ऑफ अ रेट्रोबल्बार न्यूराइटिस, isn't it? This is one condition in ophthalmology where the patient sees nothing, the doctor also sees nothing because the retina is absolutely normal. ठीक है बेटा? Yes, hard is hard to use but good vision. Hard is hard to use but good vision, है ना? So quickly, 𝗵𝗗 chart. Please remember, this is not a single chart. This is a plate of, this is, a booklet of 38 pages. Some booklets have 34 pages also. This is 𝗵𝗗 chart. The problem is that blue color is not tested. Red and green colors are tested, but blue colors are not tested. Okay, Farnsworth Munsell 100U test is the best test, the most sensitive test. ठीक है ना? RBN में क्या होता है? The patient is a middle-aged female. Generally, 20% of optic neuritis, 20% of multiple sclerosis patients have RBN at the presentation. ठीक है? They come to you with a sudden loss of vision. RAPD is present. Decrease in color vision is present. And you must give IV methylprednisolone for the treatment urgently. ठीक है? Very good, Dr. User. 100 नहीं है, actually it is 85 hues which this test is testing. यही कहना चाहते हो ना बच्चे? Very, very good. डॉक्टर यूजर ने बड़े अच्छे अच्छे नाम लिए, NMOSD, yes. So the other causes of optic neuritis apart from multiple sclerosis is neuromyelitis optica spectral disorder, जिसको पहले डेविक्स डिजीज भी कहते थे, ठीक है? That's very very good. Anything else, something very tough which you want to tell us? आजकल NMO नहीं कहते डॉक्टर गजेंद्र, आजकल कहते हैं न्यूरोमाइलाइटिस ऑप्टिका स्पेक्ट्रल डिसऑर्डर्स, ठीक है? इसके अंदर बहुत सारी चीजें दे हैव इंक्लूडेड, वो शायद मुझको भी नहीं पता है, ओके? चलो, लेट्स नाउ मूव टू अनदर वेरी इजी क्वेश्चन, बट यस अ वेरी वेरी इंपॉर्टेंट टॉपिक हियर. I want to tell you what is confrontation test. This is my most important thing. So we have an old patient coming to us with a decrease in vision in the right eye. There are a lot of systemic conditions which the patient is presenting. Confrontation test ने क्या बताया? That there is a problem in the right temporal field and left nasal field. So guys, can I simply say the patient has a right homonymous hemianopia? बिल्कुल है ना? What is this right homonymous hemianopia? If this is the left and the right visual field, the problem is here. Yes? So this is a right homonymous hemianopia. Without looking at the options, my best option will be the left-sided optic tract. Okay. Today morning in the group, we was discussing something about right homonymous hemianopia in context with the arteries. I am not very convinced with that question, frankly speaking. Okay. Because if you are talking about this particular thing, more or less, this is optic tract. Generally, we don't see homonymous hemianopias in cortical problems, because in cortical problems, usually we get some kind of sparing. Usually we don't have such perfect defects, okay? Incongruous defect dikhenge, ya some kind of sparing is there. But generally, this is your typically a right homonymous hemianopias. Guys, macular sparing is what we generally get in the cortical lesions. Okay, beta? So that question which were discussed in the group, this is not very convincing or very good question. Now, another expected question is something from this. Can you answer what is this condition? इसमें मरीज को हुआ क्या है? What is the problem here? Instead of giving you the black areas, I have actually given you the seeing areas. So can I say the problem is on the left side, and here the diagnosis is left homonymous hemianopias? Yes or no? So this is another way of asking you the similar question. I have given you the seeing areas instead of the non-seeing areas. Am I clear, friends? Am I clear? Okay, bache, they can ask you such type of questions as well. Chalo, let's now move to some kind of dystrophies. Another important expected question. So we have a young boy coming to us with a central decrease in vision. There's a family history of similar complaints. His retina shows some pigments. His ERG and EOG are normal. What is the diagnosis? So guys, can it be RP? No, it can't be RP. Though it's meeting the same thing. Family history हो सकता है RP में. Central vision decrease से पहले. Earlier, usually we'll have night blindness. Remember, ERG will be abnormal even in very initial stages. ठीक है बच्चे? So RP is out. Family history हो सकता है. Central decrease in vision भी हो सकता है, but not in a young boy. It will come at around 25-30 years of age, not before that generally. ठीक है ना? Now what about road cone dystrophy? Definitely यहाँ पे भी ERG खराब होएगा, है ना? Best disease में तो हमको पता ही है. We all know in best disease the diagnosis is made by EOG. So EOG is definitely abnormal. So by ruling out everything else, my diagnosis here becomes Stargardt's disease, and definitely the answer is Stargardt's disease. My students are on fire and they have told us everything. तो इसको क्या बोलते हैं ये भी बता दो भाई. ये कौन सा पिक्चर है? ये क्या है? So guys, can you see that there is a problem with the 𝗵𝗂4 gene, है ना? ये डॉक्टर यूजर ने बड़ा सही बताया है. So this is your 𝗵𝗂4 gene. There is a problem. This इस जीन से होता क्या है basically? So basically, you know, there are some end products, the waste products of vitamin A metabolism. हमने वो Waltz का A cycle पढ़ा है ना, vitamin A cycle. So there are some waste products. Okay. Now, if there is a mutation here in this kind of gene, those waste products are accumulated inside the retina. So, in the form of some pigments, in the form of lipofuscin. So, actually, lipofuscin is getting accumulated in the retina. And this is resulting in the dark choroid appearance on FFA. Okay, choroid पे जो normally whitish सा hue आता है, that whitish hue is gone. You will all see this black areas because lipofuscin blocks the choroidal hyperfluorescence. Lipofuscin की वजह से जो normal choroid का white pattern दिखता है, we are not able to see that whitish pattern. Am I clear, Dr. Vinay, or it's going over the head? चलो, very quickly, very briefly again. मेरी तरफ देखें, सुने. So, it is a problem which runs in families because there is a mutation of 𝗵𝗂4 gene. 𝗵𝗂4 gene codes for a protein which is very important for vitamin A cycle. If this protein is mutated, if it is not functioning well, the waste products are going to accumulate in retina. Lipofuscin accumulates within the retina. Because of this accumulation, the retina appears having multiple pisiform accumulations in the retina. इस accumulation को हमने क्या नाम दिया है? We say pisiform flex in the retina. Later on, we will see bronze beaten metal appearance. Both of them are questions. Okay, fish tail flex बोलते हैं इसको, pisiform or fish tail flex. Now, remember, patient generally has an early presentation, 10 years, 12 years, and he has a central decrease in vision. Remember, this is very important. Okay, even in the early stage, there may be some kind of, problem to the patient, but ERG and EOG may be normal. So that's how we have come to a conclusion that this answer should be the Stargardt's disease. Now, something very brief about Best disease. Best disease को 4 form में discuss किया गया है. There are 4 important stages. Pre-vitaliform stage where the vision is absolutely normal, but EOG is slightly abnormal. Vitaliform stage where we have classical egg yolk appearance. Pseudo-hypopyon where this lipofuscin pigments again is getting absorbed, and this is your scrambled egg appearance finally. So, okay, so you may have some kind of picture question from this topic. Okay, ठीक है बेटा? Dr. Vinay, have you understood why this is not RP? RP में सबसे पहले night blindness होता है. You don't get a central loss of vision in a child. Secondly, you may have a family history, but in all the stages of retinitis pigmentosa, the ERG will be abnormal. Am I clear now? Chalo, something beautiful from glaucoma. Batao, by my favorite question. Hanji. So we have an old female complaining of frequent headaches since 2 years. CT scan normal hai. But when the patient comes for an eye checkup to me, I found the pressure is also normal. Okay, pressure is also normal. When I checked her disc is also kind of normal. Gonioscopy bhi normal hai. But the moment I carry out the visual field, I found findings. I had a sedal scotoma in right eye and the paracentral wing shape scotoma in the left eye. So what is the diagnosis here? Very good, very, very quick. The correct answer is normal tension glaucoma. Very nice. Dr. User, will you enlighten us with your name? Can you just let me know who is my Dr. User here? All right. So this is not POAG because what are the things here? The pressure is under the normal range, isn't it? Disc is also in the normal thing. So POAG is gone. Glaucoma to hai na, because we have findings in the visual fields, isn't it? Okay, Dr. Mishra, you're going very, very good. Now, ocular hypertension kyun nahi hai? Because the pressure is again in the normal age. So it's very much suiting towards normal tension glaucoma. By the way, my next question, will you like to treat him? Would you like to treat him? Yes, definitely treatment will be there. Bilkul, treatment karna hi hai. So guys, normal tension glaucoma is a very different kind of identity where we may have disc changes, where we may have a pressure related symptoms. You know, this patient develops a glaucoma not because the pressure is high, but the problem lies at the optic disc. Optic disc pe perfusion pressure is not good. The vascular supply is not good. That's why the patient is developing a glaucoma even in the normal range. मेरे लिए 18 का pressure okay है, but not okay for that patient. That's why he is developing a glaucoma. Got it, everyone? Got it? Now, very, very quickly, the disc-related signs. It's a beautiful mnemonic here. H1N2 lab 3. Hemorrhage at the disc, notching nasalization, laminar knot sign, and 3Bs, which are bayoneting, bearing, and bean pot cup. So you must remember these signs as well. Now, a picture question. ये क्या है? Anyone? This is your H1, hemorrhage at the disc. Very classical for POAG. You may see this in normal tension glaucoma as well. Disc hemorrhage, बहुत important question. ठीक है बेटा? Now what is this? This is Humphreys field analyzer. है ना? Humphreys field analyzer. We call this perimeter also. This is a static type of perimeter. Most of the time we are using this kind of perimeter nowadays. Okay? Now, very quickly, these signs are also very important. Isoptric contraction, bearing of blind spot, and so on. Please remember, last year we had a question from Ronay's nasal step. Yaad hai? This was the question last year, and I said beautiful question it was. Hai na? So this is your peripheral nasal step. Remember, in the last, the nasal the temporal island can be left. Okay. Now, can anyone diagnose what is this field defect? Can anybody name what is the field defect? Anyone? What is this field defect? ना बच्चे papilledema क्यों है? We are talking about glaucoma only. From these, what is this defect? इन्हीं में से ये क्या है? सोचो. हाँ जी, क्या है? Okay, so this is your visual field printout. Okay, can you see this arc shape defect? Arc shape. So if this is an arc shape defect, I will call it arcuate scotoma. ठीक है बच्चे? Arcuate scotoma. All right? ठीक है? Yes, Jerem's scotoma is another name for arcuate scotoma. Absolutely beautiful. Jerem's scotoma is also the other name of arcuate scotoma. So both of them are correct. Absolutely correct. Wonderful. Very, very good. So the next question, a very easy question. We have a young man having a history of redness in eye since many months. He has been using topical steroids, but now he developed similar complaints again. This time, when you see the patient, there is a problem. So there is a staining of the cornea by green color. So what is the best answer here? Easy. क्या हुआ होगा उसको? So guys, this is a beautiful picture of a geographical ulcer. That's how geographical ulcer presents. Now, have a look at his complaint. एक patient कह रहा है उसको बार-बार हर थोड़े दिनों में redness हो जाती है. Probably he had the dendritic kind of ulcer also probably. And now the moment he has used the topical steroids, what could have happened? All the dendrites will coalesce to get together. They will join together and it will lead to a very big ulcer. This is called as a geographical ulcer, also known by the name of amoeboid ulcer. Okay? Yes, very, very good. This is a geographical ulcer. So please remember, in cases of dendritic ulcer, this is how the dendritic pattern is. Can you see the knobs? These are the knobs at the ends. That is why this is called as a true dendrite. True dendrite matlab knobs at the end. Remember, we should not use steroids in case of dendritic ulcer. It is absolutely contraindicated. The moment topical steroids are used, it will turn into a very big ulcer. This is called as geographical ulcer. Rather, he should go to a doctor, properly get it checked, and then get treated here. ये recurrence के लिए बोला है बच्चे मैंने herpes. Recurrence हो रहा है ना? Recurrence में herpes is a very, very prone organism because it is a recurrent type of, it gives you a recurrent kind of ulcer. So all of you are absolutely correct here. Very good, wonderful question. But picture I wanted to show you. Okay? So we are moving to the last question. We have a young female coming with a problem of retraction of her left eyelid when she eats or drink, which becomes very irritating to her. So what do you think is this condition? Isko kya naam diya hai beta? So can I say this is the picture because she's sipping and there's a retraction of lid? There's a retraction of lid. Yes. Similarly, in the other picture, can you all make out there is a ptosis where the moment the patient moves the jaw to the other side, there is an improvement in ptosis. Can you all see? The ptosis improves. Hai na? So what has happened? What is this phenomenon? Can I call this phenomenon to be Marcus gun jaw winking phenomenon? I hope you remember that. So this is nothing but misdirection. What is happening? The third nerve is not supplying the LPS. LPS is rather supplied by a branch of the fifth nerve, the trigeminal nerve. So mandibular division, which also supplies the jaw, the movement of the jaw, like ipsilateral lateral pterygoid. So the moment the pterygoid muscle is contracted, there is an improvement in ptosis. Look at me. Okay. So both of them are supplied by the fifth nerve now. LPS is not supplied by the third nerve. This is what you have. Yes, abnormal friendship of the nerves. Yes. So it is the mandibular division of the fifth nerve, which is now misdirected to the levator muscle. Okay. You can have picture questions from this topic. You can actually have a question here that it is not related to third nerve. Surgery के बाद नहीं होता, ये तो ptosis है. It is a complicated ptosis. Thyroid is no way related to it. So you must know this particularly. So guys, we are done with all the questions. I hope you learned something today. And anybody who scored 20 of 20 today, anyone? Like I have so good students today with me on the chat. I'm really happy to teach you guys and very proud that our students are doing very, very good. I'm sure you'll be clearing your exam with very good ranks. You will get what you actually want. So I hope you liked something today in the discussion. You learned something also and you became more confident of your knowledge. You are prepared very, very well, guys. I'm really proud of all of you. So that's all from my side. I'll request all of you to join the WhatsApp group that we all have at DocTutorials. The faculties are very, very approachable. That's the best part about the DocTutorials team. We have taken every day. Today is the last session, probably, I think. This is the last session from our team. So from my side, Dr. Shivani and everyone at DocTutorials, we believe that our students are prepared very well and they'll really do wonders in the exam. They are having a very good positive frame of mind. And I'm sure that you'll do really, really great. During the life interact, Dr. Vinay, you got 20 of 20. That's great. Very nice. I'm sure many of you have got all correct answers, but the main thing is getting your confidence boosted. Isn't it that you become more confident, you are happy solving the questions and you learned something also, isn't it? That is the most important part of this kind of a little test that we are having at DocTutorials. So that's all from my side, guys. I won't waste much of your time. If you have any kind of doubt, you can ping me. You can write down to me at the DocTutorials WhatsApp group, or you can ping me at Instagram. You can find me by the name of Ophthalmology by Dr. Shivani at Instagram. So thank you very much. Thank you, Dr. Vinay, and thank you, everyone. Good night, everyone, and best of luck.